Welcome, my digital pathology trailblazers. So excited to be here today. And for those who are joining for the first time, my name is Dr. Alex Zhurav. I'm a veterinary pathologist by training, and I'm a digital pathology enthusiast. I believe that digital pathology is the gateway to fast diagnosis, and that's what patients have right to. So I teach about digital pathology and also bring the right businesses in front of digital pathology trailblazers. It's a mouthful, I know, but I realize I never introduced myself for those of you who are here for the first time. I'm going to shorten it for the next time. But I see you joining, and I'm so excited because today is a different time. It's Saturday morning. Like, who wakes up on Saturday morning to review digital pathology papers? Well, me, as you can see, but also there are people online. So whenever you're joining, let me know where you're tuning in from and what time it is for you today. I see there's people joining, and as you join, let me know. Just like show me in the comments, and that you can hear me, you can see me, and that you are here on Saturday with me as well. In the meantime, I'm just gonna start. By the way, of course, you're noticing my earrings, right? So you're gonna hear about those earrings later at the end of the live stream a little bit more. And because they're so beautiful and I wanna share them with you. But now, without further ado, let's disperse because they are so cool today. I actually enjoyed reading them, believe me or not. And I don't enjoy reading all of them. Sometimes it's muscling through them, but today it was a breeze. Oh my goodness. And we have people from Tunisia. So cool. Thank you so much for joining. I think, are you here the first time? Let me know if you have already been here before. And before I tell you some more about other things, let's talk about multiple instance learning for the detection of lymph node and omental metastasis, carcinoma of ovaries, fallopian tubes, and peritoneum. Have you noticed that I now have like purple color of my pen? I decided that it is closer to H&E than orange, so let's see how that goes. This was published in Cancers, and this is a group from UK. Leeds is a hospital that is leading in digital pathology. These people have been doing digital pathology, I think, since digital pathology started as a discipline. So for this particular paper, the background is that surgical pathology of tubo-ovarian and peritoneal cancer. Let me, no, my microphone is okay. Sorry. If at any point you like stop hearing me, let me know in the comments because I don't want to go on mute for too long. I'm going to be losing you. So again, whenever you're joining, let me know where you're tuning in from. And if anything technique wise or like setup wise doesn't work, let me know. And we're back to the tubo-ovarian peritoneal cancer. It has a lot of work to be done to diagnose it. And what do I mean by that? We have a bunch of other tissue than just the tumor tissue to evaluate. And there is a large amount of non-primary tumor-related tissue requiring assessment of the presence of metastatic disease. And we're talking about lymph nodes, omentum, including, and these are resection cases, so not just biopsies, and also anything else here. Yeah, volume. And I have a little smiley here. Why am I happy about this volume being so big? Not happy about volume being so big, but I'm happy because this is a fantastic use case for AI, and you're going to see why. Actually, have you ever heard of this challenge to detect metastasis in lymph nodes? It was called Chameleon Challenge, one of the first challenges. Oh my goodness. Okay, I have to stop because we have the first time, a person who's joining first time the live stream, but has been following the newsletter for years. And this makes my heart just like It's so heartwarming. Thank you so much for joining. And now, Chameleon Challenge. 2016, 2017, different image analysis companies were detecting metastasis in lymph nodes. And they did pretty well done. They detected a lot. And here, this is the approach that is being used. So let's check the method. We used attention-based multiple instance learning with a vision transformer foundation model to classify whole slide images. And we are classifying as either those who have ovarian cancer, containing ovarian carcinoma, metastasis, or not, which is such a fantastic task for AI. Like you don't have to screen it, you get it pre-screened and then present to you. So training and validation, there it was conducted with 5 whole slide images of surgical resection specimens of 404 patients at this Leeds teaching hospital, those trailblazers in digital pathology. And what happened here, like the results were very good. So or the area under receiver operating curve of 0.998, and this was ensembled classification from holdout testing, and the balanced accuracy of 100%. Like, really? But I believe it actually, because this task is visually simple in terms of distinguishing the cancer from the surrounding tissue. So visually, you don't have doubts when you see it. But the problem is that there is so much tissue to go through and like so many square micrometers to cover. And this is the problem for human eye and basically like our cognitive and visual strain. Whereas for AI, it's not a problem at all. So I actually believe these results. What else do we have? In the lymph node set, we have an OROC of 0.963 and a balanced accuracy of 98% in the omentum set. So the 100%, the better. It's all are like really good, almost perfect results. Where the omentum, we also had fantastic results. Inclusion is there's great potential in the identification of ovarian carcinoma nodal and omental metastasis, and this could provide clinical utility through its availability to pre-screen whole slide images prior to histopathologist review. A big heart to this application, because this is, like I say, visually easy task that constitutes a big burden on the pathologist and could totally be done with AI, pre-screened with AI, and then shown to a pathologist information. So it's still computer-aided diagnosis, AI-assisted diagnosis. I think we're going to have this abbreviation in another paper, ADD? No, AIDD. Something like that. We'll see. But anyway, so the pathologist is still in the driver's seat of this particular diagnostic process, and I'm struggling here with my mouse. The pathologist is still in the driver's seat. We want it that way, and that's how it stays, but with the superpower of AI. So let's go to our next publication. In our next publication, this is something at Scientific Translational Medicine. We have a group from San Francisco in a second, but we're talking about DeepBeam, a high-performance generalizable, I don't know why my underlining is so crooked here, a deep ensemble, I don't know how to pronounce it, for bone marrow morphometry and hematologic diagnosis. And I was like, what is this ensemble? And basically it's multiple models. So it's not just one model. And this group is mostly from the US. We have San Francisco, New York, Boston, Memorial Sloan Kettering in New York, North Carolina, Chapel Hill, Oakland, California. These are usual suspects in the digital pathology space. So let's talk about this particular application. Oh, and we have new people joining on LinkedIn. Fantastic. Thank you so much for joining. Let me know if you have any questions. Let me know where you're dialing in from. So deep heme. What's the problem here? We have this cytomorphological analysis of bone marrow aspirates. This is a pivotal diagnostic workup for all hematologic disorders. When there is something flagged on your blood work, then it triggers making a smear from your blood, and then at some point, maybe if the hematopathologists decide, okay, more work, then that's going to be the bone marrow aspirate. And so bone marrow aspirate is a bunch of different level of development blood cells, right? Both white blood cells and red blood cells from the very beginning to when they are mature. So a bunch of very similarly looking little cells. And why am I saying that? I'm saying that to pre-frame this skill of this prone, highly complex and time consuming. And I can say yes to that. And anybody who has seen a bone marrow smear can also confirm that. Okay. Oh, and we have even more people joining on Saturday. You guys are amazing. I love this. This is fantastic. Let me know where you're dialing in from. So, going back to the paper, bone marrow aspirate evaluation difficult. So let's have the AI help us, right? Deep learning based models for the automatic classification of bone marrow cell morphology demonstrate the potential to improve diagnostic efficiency and accuracy. Yes, whenever AI can recognize something well on the image, it can help. The problem is when it doesn't recognize something very well, and when it's visually difficult to recognize, often it doesn't. But in this case, we have the potential to improve everything. But the existing deep learning approaches are not that fantastic. So they also they're not that fantastic compared to human evaluator, and also not that fantastic in terms of generalizability beyond the training data set, right? Or beyond a single data set. So what they did, they curated a data set from the University of California, San Francisco, and it included a training set of 30,394 images from 40 patients with morphologically normal marrows, so normal bone marrow. And then they had a test set, 8,507 images from 10 different patients. And all derived from 400 equivalent whole slide images. So we have images and whole slide images. So we have probably snapshots, screenshots of images and that are derived from 400 whole slide images. What is this 400x? This is the 4x objective, which actually surprises me a little bit because I was expecting bone marrow evaluation to be done on at higher, probably the visual pathologist evaluation is, but here they trained on 40x, which is fantastic because if it works on 40x with AI, then the scanning is faster. And then we developed Deep Heme, a snapshot ensemble deep learning classifier. And snapshots of a classifier are basically different versions of this classifier. So different levels of training of the same classifier. So you don't have to retrain from scratch, and then you deploy them all on this particular data set. And this outperformed previous models in accuracy, which is fantastic. And this while expanding the total number of differentiable, the ones that you can differentiate cell classes. So before it was a limited number of cell classes that the model could differentiate, and now it's a lot more. And I see more people joining. So whenever you join, just say hi in the comments and let me know where you're dialing in from and also what time it is for you. So we have this snapshot ensemble of models that recognizes more classes, and then they externally validate. So how cool is that? I mean, it's just good science, right? But because I was exposed to bad science before, every time I have a test set, training set, external validation, I'm ecstatic that they actually did the work that they were supposed to do. Because in the beginning of the digital pathology days, you would go to conferences and you would hear like amazing performance on the training set. And that's not how you do this computational pathology. You do need a training set, validation set, and all these other different data sets. Otherwise, you can just throw away your model or just run it on your training set in a loop, endless loop. Okay. So, and then this external validation was on the data set from Memorial Sloan Kettering, and aspects super active in the space of digital pathology. They even organize digital pathology workshops. So if you ever get the chance to go there to learn digital pathology, please do. So they included 2,694 images from 10 morphologically normal patients and 11,076 images from 655 patients with normal or diseased marrow. And it demonstrates ability. Also at the level of individual cell classification, they systematically compared deep heme to 3 medical experts from different academic hospitals, and the accuracy was comparable or exceeding the one of human experts. So I am so happy that we now have something, or these are not really like commercializable tools, but this is already research done proving a concept that this stuff can be done, which is amazing. Our next paper, abstracts, is going to be AI for head and neck. Before that, I'm going to give you an update, which is the next conference I'm going to. Actually, on Monday, I'm going to STP. So this is going to be relevant for my fellow toxicologic pathologists. It's the annual meeting of Society of Toxicologic Pathology, and I am honored to speak there about digital pathology and AI in neuropathology. So, yeah, these presentations are invite only, so I feel pretty honored that I'm going to be speaking about that. But that's just like my ego and feeling good. Oh, somebody invited me to speak. But the more relevant thing is that there is interest in AI and digital pathology, and the conference attendants and the organizers want to know, okay, what is out there? So yeah, I cannot say what I'm going to be talking about, but hopefully I can record my practice talk and then maybe share it with you in one way or another, or not. We'll see. But STP is my next conference. Let me know which conference you are going to next time, either when you're watching live or as a recording. Recording. Let me know where you're going next. From the digital pathology conferences or pathology conferences, because maybe we can meet each other there. And now let's move on to AI for head and neck squamous cell carcinoma, from diagnosis to treatment. So this is a review that is going to tell us about, okay, what's going on for head and neck and when it comes to digital pathology, AI, and all these things. And this head and neck is a globally prevalent malignancy with high morbidity and mortality. And I think that like all the cancer papers start like this type of cancer has high mortality and high morbidity. But these are the rules of writing papers, right? You have to do an introduction, and specifically in the abstract where people from outside your area are going to do it. And after this one, I'm going to address some comments, because I'm getting some comments. Thank you so much for chatting. So we have high morbidity, high mortality, and despite the therapeutic advances, patient outcomes are hindered by tumor heterogeneity, treatment-related toxicity, and also limitations of traditional prognostic tools. So obviously we want to leverage AI to improve personalized head and neck squamous cell carcinoma management by integrating, and this is the keyword hour, integrating, this is our keyword for this one, radiologic, pathologic, and molecular data into actionable information and insights. And this is a review of recent developments in AI application across head and neck cancer. So AI has shown promise in enhancing diagnostic accuracy through automated tumor burden assessment, extranodal extension prediction, and endoscopic image analysis. So deep learning applied to radiology and digital pathology enables extraction of prognostic features that may inform risk stratification and treatment de-escalation. And again, let me do this, but a different color. Can I do different color? This one. Multimodal. Multimodal is the integrating, and multimodal are our keywords here. Because multimodal AI models, they fuse imaging, histopathology, and electronic health records, have demonstrated superior performance in survival outcomes compared with unimodal. So we have multimodal versus unimodal. And these are better. And these are not that great. So this is basically what they're saying here. And additional applications may include early toxicity detection during radiotherapy, adaptive treatment planning, surgical complication forecasting, predicting immunotherapy response, identifying imaging and histology correlates of tumor immunogenicity. So there is potential, as we know, and but there are also barriers to clinical translation, because we don't have explainable models, because the implementation is difficult, because there is a continued development necessary, and adoption is lagging. So all the classical problems with digital pathology are adapting actually any new technology, like adoption. But I would want the digital pathology adoption to be more than what it is. But you know what? Let's make it happen together. What I wanted to say is that on Wednesday, histology live stream, and it's so funny because this live stream, those publications, so comfortable, so confident with how to present them, with how to go through these abstracts. But this is after like 24 times, and the histology one, even though like I'm fluent and I'm like, I need to know histology. I know histology, and I know that I know histology. I was so much less confident on this live stream. So if you go to my YouTube channel and want to check out a less confident presenter who is the same person who's presenting to you right now pretty confidently, I would say, you can check this other live stream. And when I finished, I was like, that wasn't that great. Did those people even like it? Did they learn enough? Was I not rambling too much? I probably was. But then I thought, hey, my first DigiPath digest sucked as well. So I just gave myself permission to suck at the beginning of the process, and I'm going to be improving it. And we have a participant here from Nigeria, and we have a long comment, who developed a tool counting and classifying blood cells from multiple blood smears images as a personal project. And how can you improve this tool for better accuracy and performance and other functions? So this is a perfect comment for our previous paper, right? Deep heme. Where's our deep heme? This one. Get this one, deep heme, a high-performance generalizable deep ensemble of bone marrow morphometry and hematologic diagnosis, and check what they did and check what you can replicate in your project, and let me know how that went. Let me know which methods you went for, and how you're gonna be using it. Are you gonna be using it in practice? Is it for research, or is it for anything? I'm just curious. I'm always curious about these digital pathology projects, especially in the under-resourced areas, because I think this is where digital pathology has the biggest potential. But this is also the place, or the place, it's not one place, it's different places, where we have to look at alternative low, like super lean methods to deploy it. So yeah, I'm curious. Let me know. And what are we? Oh, we are talking about something super cool, because here's Tiffany. Because this paper called "Enhancing Organ Allocation Efficiency: A Pilot Study Evaluating AI-Assisted Assessment of Donor Kidney Pathology" was done by TechSite. And TechSite is a digital pathology place sponsor, so big shout out to TechSite. I met the team at US Cap in Boston a month or two ago. When were we there? Probably in March or April. Anyway, I met their team. I have recorded a podcast with Tiffany and Ben, the CEO of TechSite. We also have a demo of the platform that was used in this very paper. It's funny when I show it digitally, it's on this side, but actually it's on this side for me. Anyway, so I saw the platform from firsthand. I know their vision behind the platform, and this publication is an example of what they did with it. So let's dive into it. Shout out to Tiffany for helping with this publication. So the purpose of the study was to evaluate effectiveness of AI. Effectiveness of AI-assisted review. So this is AAR, AI-assisted review system for improving diagnostic accuracy, efficiency, and concordance with expert assessment during the evaluation of donor kidney viability. I like these papers this week because they had like very practical applications, and like the ovarian cancer screening for metastasis. And this has to be done fast, accurately, and AI could help. So 60 H&E stained frozen section kidney biopsies. So this is important. Frozen, why is it not? Okay. Frozen sections. Most of this stuff is being developed on FFP, formalin fixed paraffin embedded material, and for some stuff you need frozen sections, right? For intraoperative, for fast stuff, you don't do the full formalin processing, you do frozen sections, or you can also do direct to digital at some point when the method is developed. Like another digital pathology place sponsor does Muse microscopy. But here we have frozen sections, and they were frozen sections from explant kidneys obtained for organ donation. These were evaluated, and a board-certified renal pathologist established ground truth through manual digital evaluation on the TechSite Fusion platform. So there's another thing that I liked in this paper, other than that I know the people and that I just talked to them at the conference, and they have a pretty good product. I'm going to tell you about it in a second. The slides were independently reviewed by an AI algorithm, a board-certified pathologist, reviewer 2, and a board-certified transplant surgeon, reviewer 1. After a washout period, AI-assisted reads were performed. The performance of this AI-assisted review and the manual digital review. So this is where I have my heart. They were not comparing this stuff to glass. We already passed that. Glass is okay and digital is okay. And now we can do on digital and then compare digital review with AI-assisted digital review. So we're like advancing. And that's why I have a little heart here. Manual digital review. We're not doing glass comparison anymore. So this was compared to the ground truth for total and sclerotic glomeruli. So this is counts. So this is also important. You have a specific object that you can detect with AI, and you can count it. Like, perfect use case for AI. Beautiful use case for AI. So as well as concordance with kidney viability thresholds, and this threshold was 20% sclerotic glomeruli cutoff rate. And secondary outcomes included also comparison of review times and concordance rates for the AI-assisted and manual digital, and AI analysis alone with the ground truth. So what were our results across parameters? We had concordance. This is amazing. We have concordance of AI assisted versus ground truth. And then there were different like numbers for different reviewers. But basically, agreement at the 20% sclerotic glomeruli threshold for kidney viability was 98.33% for both the AI assisted and manual. So it's very good. And also AI assisted, it reduced mean time, review times minutes by 54.83%, half of the time when you use AI versus non-AI. So per slide review, times decreasing from 17 minutes to 8 minutes 35 seconds. That's a lot of time for reviewing this freaking biopsy. 17 minutes for a kidney frozen section biopsy, because you have to count these glomeruli, I guess. And now you could reduce by more than 50%. How cool is that? So this all different, correlations, Pearson's correlation coefficient, concordance correlation coefficient for AI-assisted review were generally higher than manual review, particularly for the percentage of sclerotic glomeruli. Does not surprise me at all, because we have a computer counting and a person counting. So we're not that great at counting. I'm going to tell you a little story. When I was little, my dad, I don't know how old I was, like maybe 11. So, my counting skills maybe weren't that great, but like I was focusing. I was like, I even had my abacus or whatever, and he gave me something to calculate, and then of course he corrected, and I was wrong so many times. And that was when I was 11, and I realized people are not that good at counting, no matter how hard you try. So I learned that lesson early in life. Okay, but basically, what our TechSite colleagues are saying here, and that AI assisted review has improved alignment with ground truth. And they analyzed for it, and there was no systematic bias, and AI assisted review aligning more closely with ground truth compared to manual review for both reviewers. And the conclusion is that the TechSite algorithm reduces review time while maintaining accuracy and concordance with experts, promoting AI adoption to improve workflow efficiency and expedite transplantation decisions. So that's something that has to be done like super fast, transplanting stuff. So if you can leverage AI, fantastic. And also this platform, the Fusion platform, it basically fuses your visual manual digital workflow with AI assistance. So you can have this algorithm probably when it's mature enough and plugged into the Fusion platform and use it whenever you need to use it. And I'm so happy that this is also developed on frozen sections. So I think we have one more. So guys, don't leave yet. Stay. One more, and then we can go about our weekend. And we have AI agent. Let's talk about AI agent. This is a relatively new concept. Stay with me, and if you're just joining or watching the recording, let me know where you're tuning in from and what time it is for you. And then at the end, I'm going to tell you a bit more about these earrings. Actually, if you want to learn more about these earrings, I'm going to put something on the screen. You can it's called DPP Store. You can see them there if you're already thinking of tuning out, but don't, because we have this agent paper to discuss. So let's discuss it. In the meantime, check out the earrings, and we're going to be talking about development and validation of autonomous artificial intelligence agent for clinical decision making in oncology. The first time I heard about agents was just before I recorded a podcast with a radiology expert, Dr. Nina Kotler, and she was explaining it nicely in the podcast, so you can have a look at this particular podcast. But here, this is a group from Heidelberg, and they are freaking cutting edge. I've heard of them, and the person in charge there is Jakob Nicholas Katter. You're gonna see his name on many digital pathology publications. I heard about them when I started in the digital pathology space around 2016. So we're like a decade into this stuff, and they were already cutting edge there. So what they are saying is that clinical decision making in oncology is complex. We agree with that. And it requires integration of multimodal data and multi-domain expertise. We also agree with that. And we already saw in this other paper, multimodal is a lot better than unimodal. And they developed and evaluated an autonomous clinical artificial intelligence agent leveraging GPT-4. So we're talking about the generalized pre-trained transformer, our ChatGPT friend, with multimodal precision oncology tools to support personalized clinical decision making. And this system incorporates vision transformers for detecting microsatellite instability and KRAS and BRAF mutations from histopathology slides. So we have a vision model, we have a text model, and I don't know what else they have, a search, RAG, retrieval augmented generation. They also have MedSAM. This is a radiology model for radiological image segmentation. I'm going to tell you something about these mutations and other the microsatellite instability, because there was a podcast with a person from their team, with Oliver Saldana. Yes, and it was a good one. Check the one with Oliver Saldana. And what else did they do? They did web-based search tools such as OncoKB, PubMed, and Google, and evaluated 20 realistic multimodal patient cases. And the AI agent autonomously used appropriate tools with 87.5% accuracy, reached correct clinical conclusions in 91% of cases, and accurately cited relevant oncology guidelines in 75.5% of the time. And you may think, oh, 75% of the time, that's not so much. But when you compare it to GPT-4 alone, this integrated agent improved decision-making accuracy from 30%, which is like, don't even approach me with that number, to 87.2%, which is like, oh, let me work a little bit more on this and it's gonna be clinic ready. So these findings demonstrates that integrating language model with precision oncology and search tools substantially enhance clinical accuracy, and they establish a robust foundation for deploying AI-driven personalized oncology support systems. And that were all the papers that we were supposed to discuss together today. What I want to show you, it's always like not showing me. I want to show you the earrings that I was bragging about, and I'm gonna keep bragging about them because I'm so proud of them. We have three different designs. We have multinucleated giant cells, we have cartilage, and we have Alcyon blue special stain of colonic crypts, and they are such an amazing conversation starter. So if this is something that you like for yourself or for somebody who I take them to conferences and people started recognizing them. So I thought, hey, let me make some for digital pathology trailblazers. I don't have too many of them. Oh, and I see somebody scanned this QR code. Thank you so much. I don't have too many of them. I only ordered 25 of each design, and actually I probably have less because I have to send out some, but I didn't count how many. So if this is something you're interested in, check the QR code. And obviously, if you are here the first time, or if you don't have the book yet, and by the book I mean Digital Pathology 101, all you need to know to start and continue your digital pathology journey, this is available for free through this other QR code that I'm showing on the screen right now as a PDF. And if you want to buy it on Amazon, then you can as well. But what I would rather recommend at this very moment, I mean, you can do both. It's not expensive. It's like, I don't know, I put the like lowest price I could do so that it's accessible. But the one from QR code is free. It's a PDF. And if you have the PDF, you're going to be on my mailing list. And when the new version comes out, because this one was in 2023, this was like baby chat GPT, and now we have like multi-model stuff, foundation models, all that stuff. So I need to update the AI chapter. But if you have the previous versions, you automatically will get the next version. So don't worry. For the digital, don't wait for the next version. Just grab the one right now. And when I have everything updated, you're going to get the updated version. And also, give somebody these earrings or get them for yourself. Thank you so much for joining. I always appreciate it. It was Saturday morning, so you are amazing. Thank you, my digital pathology trailblazers, and I talk to you in the next episode.